This is what we all should be, happy. And our life should be joyous rather than being in pain. But pain management is very confusing. And the first thing we all do is we Google. And when you put in pain, you find 255 million sites talking about pain. When you just put in endometriosis, it drops down to 7.5 million. Or if you put pain and endometriosis. Interestingly, endometriosis and diet is 4.5 million. So there's just so much information out there and not always correct. But you can just get swamped and overloaded with absolutely everything, and you don't know where to go and you don't know how to find the right answer. I was really surprised to find that Panadol has its own website. And I thought, well, yeah, I'm obviously old and grey and don't get all of that kind of stuff. So the first thing to do really in pain management is to make sure your diagnosis is correct. I'm just going off on a completely different tangent, but part of my work in different things that I've done is I actually worked as the gynaecologist for the International Olympic Committee in 2010 at the Winter Olympics. And this is the inside of the athletes' village, and it was great fun. But from a doctoring point of view, a lot of what we do is great fun, including surgery. And we all like to operate. So, you know, anybody who comes in my door and says, I've got a bit of pain, it's really tempting to operate because it's great fun. And some doctors are very happy to operate, but they're not happy to follow up and see the whole thing through. So it all gets very complicated. It's easy to operate, but it's hard to look after and manage the whole process of endometriosis and pain and all of those sort of things. One of the difficult parts is the diagnosis. When I was a wee young thing in medical school, keyhole surgery was just beginning. And in those days, we thought endometriosis only happened in white, single, middle-class, 40-year-old women. And that was because they were the group who knew how to bitch hard enough about their pain to actually get somebody to listen to do something about it. And in those days, because we didn't have laparoscopic work, we only had big holes in your tummy, you had to go through a laparotomy to make the diagnosis. So those women had huge endometriomas, you know, sort of this big. They had unbelievably gross endometriosis because it was only that severity of illness could we justify that severity of surgery. As we develop laparoscopic work, it's much easier to do a laparoscope than a laparotomy. But our laparoscopies and our anaesthetics and everything have got better and better, so it's easier and easier to do it. So we're doing it more on women for much minor reasons. And we're finding endometriosis everywhere. The other problem is that the general surgeons are also doing laparoscopic work, and so they're also finding it. So they're finding it in women who are presenting with an acute appendix, who really don't have many symptoms and yet have quite significant endometriosis. They'll remove the appendix, they'll tell the lady the next day she's got endometriosis, she'll come and see me, and then I'm going to try and talk her back into another operation when she doesn't have a lot of symptoms and she doesn't know why she's sitting in my office. So there's a whole variety of symptoms and presentations which make diagnosis very difficult. And until we find a really good way of diagnosing endometriosis, of identifying all the women who have endometriosis, we will never really understand the natural history of endometriosis. And we won't really understand how effective our treatments are, because to identify how effective your treatment is, you actually have to reoperate. Now, when I was a wee young thing and keyhole surgery was beginning, we did have trials where women would go into these trials and agree to have a laparoscope every 6 or 12 or 24 months for however long the trial lasted for. But women won't do that anymore. It's really hard to talk them into it, particularly if you solve their problem or symptoms early on. So we don't really understand the natural history of the process. So it is very difficult. The other problem that I find as a gynaecologist is, you know, when you first come to see me and I've got the computer open, how old are you, what medical things have you got, you don't need now, I'm putting in all the computer. I'm gobsmacked at the number of women who say they've got endometriosis. And so now I say, well, when did you have your laparoscopy? Oh, I haven't had a laparoscopy. Oh, haven't you? Right. How do you know? And they'll say, oh, Dr. Googled it. And so there's a lot of women out there who probably have it, and they're probably right, but they don't have a definitive diagnosis. So when you do proper trials and studies and that sort of thing, it's very difficult to get really clear scientific answers. We need to think outside the box, and we need to come up with another test, preferably a blood test that's relatively easy. One of the promising areas is DNA fragmentation. A lot of you, I'm sure, will have heard now when you're pregnant you can do a blood test and we can sample the fetal DNA. There's little fragments of the baby's DNA floating around in the mother's bloodstream. And we now have the technology to look at that. And of course that's huge business for pregnant women and genetics of the baby and all that sort of stuff. The next thing that group of scientists are looking at is looking at DNA fragmentation for tumours, and so maybe we'll be able to screen for a lot more malignancies relatively soon looking at DNA fragments. But maybe, just maybe, endometriosis has a slightly different DNA than your DNA, and by able to look at the two, we might be able to find endometriosis or something along those lines. Another possibility is some sort of fluorescence where we have a marker that we can attach to something that we put in your body that will fluoresce when it hits endometriosis, so we can identify it in a way, whether that's using radiology or whatever. MRI is a big thing at the moment. You just have to think of pain and somebody sending you off for an MRI. Firstly, it's hideously expensive. And two, it's not all that accurate. But I'm talking about pain management tonight. So moving on, unfortunately, the problem again is that our treatments really haven't changed. We all remove it, which is what we all like to do because we're surgeons. But a lot of us, I shouldn't say that, that's not tactful. I was going to say a lot of us don't really want to see you after we do the operation. A lot of us do like to see you after we do the operation, but it can be quite confusing. The medical things don't tend to work, and a lot of them have gone by the wayside anyway, and the surgery. This is the nurse I worked with at the Olympics. Most of us were volunteers. She was actually paid. She was full-time STD screening. So she was swabbing, chasing up contacts, doing all of that sort of stuff. The boxes in front of her were our daily supply of condoms to the athletes' village. And we particularly liked this particular day because they came in colours. And you can see on the back wall behind her, we've done the Olympic rings in the variety of colours of condoms we got that day. But they would all go. We had bowls of condoms everywhere. And everybody at the Olympics and the athletes' village are bonking themselves silly. And that's just by the by. So we've talked a bit tonight about what is pain, and pain is a very complex thing. All the medical students are being taught to ask, you know, what's your pain from 1 to 10? So people are getting used to that to a large degree, and people know that if they come through casualty and say they've got 10 out of 10 or 15 out of 10, they'll get a narcotic. And so, you know, all the druggies are coming in and saying that. There are women who you can drive over them with a truck and they'll say, oh yeah, I've got a bit of discomfort, you know. So the 1 out of 10 is not all that clear, and it's not a particularly good way of identifying it. For an individual, it's quite good. So if she has her own scale, you know, she can quite clearly articulate that it's worse this time or whatever. I have strange group of endometriosis ladies who will be fine for ages, and then they'll come in with the most bizarre stories. You know, my hair's turned green, my nose has turned blue, my endometriosis is back, and I've booked in for my laparoscopy next week. And I've learned to accept that because they are absolutely correct. That group of women, they know what symptoms they get, they know when their endometriosis is back and when they need the surgery. And for that group of women, they'll do very well with their surgery if we can clear it all, and they'll be fine for a while and then they'll be back. So pain is very difficult to use in a clinical trial situation because it's such a complex thing. The NHS has very strict rules. They call them guidelines, but they're rules on the way people can use things and do things. So the first line of pain management for ladies with endometriosis in the NHS is Panadol plus or minus a non-steroidal. And when you say that to your patient, they all look like that. They just turn into these feral things who go, I'm not going to give it that. And so fortunately we don't have to stick to the rules, but sometimes the guidelines can be very useful. And so one of the groups of people that I see, particularly the 16, 17-year-old, grade 11, grade 12, life's pretty complex for them. They will be on so many medications that they can't tell you what day it is. So sometimes I will stop all their pain relief and they will go SPAC. But once it's cleared out of their system, their head clears and we can have a much more level conversation. So it depends on when you see people and depends on what they're up to in their story, what sort of pain relief they need. And sometimes Panadol and or a non-steroidal used in an appropriate way can be very effective. So as I say, Panadol has its own website, which I was most impressed by, because I'm not very good at websites. But Panadol is an incredibly safe drug and it's been around for absolute ever. It works on prostaglandins. With Panadol, it also has a centrally acting component, so it's not as critical as the non-steroidals. But the sooner you take it with the onset of the pain, the better, because once those prostaglandins are released and activate your pain pathway, you can drown your pain pathway in Panadol and it's not going to stop it. It actually works by stopping the release of the prostaglandins and interfering with their synthesis. So waiting until you're really bad to start your Panadol doesn't work. But as soon as you start to niggle and get your Panadol, are we having a yes, I told you so? Right, moving on then. So, you know, early is good and keep up the doses sort of to control it. The complications or side effects are really rare with Panadol. The biggest problem with Panadol is the overdose. And in general, it's, and again, this is bitchy and lightning will strike me for being so judgmental, but it's often the person who doesn't really mean to overdose. That's a gesture, it's an attention-seeking behaviour, they think it's pretty safe, they'll take 30, 40, 50 tablets and they will recover from the initial response to their Panadol, but then 48 hours, 72 hours later, they'll go into acute liver failure and they will die. And it's awful. So overdose of Panadol is really bad. And throughout my working life and working in CAS, I've come across quite a few of those. And unless you can do a liver transplant, they're dead. So for people who don't really want to kill themselves, they end up dying and they've got 3 days to say goodbye to everybody. It's yucky. So that's the biggest, worst thing. If you have a couple of Panadol, you know, the pharmacists tell you shouldn't have more than 400 milligrams a day, and they're all very careful with that sort of stuff. But, you know, some ladies need 2 every 4 hours to keep themselves under control. Some ladies need them a little bit more frequently, but short term, that's okay. Very rarely you'll get a Stephen Johnson, which if you've never heard of it, you never want to hear of it. But it will happen the first time you take your Panadol. So if you've taken Panadol and you haven't got into a Stephen Johnson syndrome, it's not going to happen to you. That's where you slough all your gut. So all the mucosa on your gut, from your mouth to your anus, just sloughs off. Not a good look. Non-steroidal anti-inflammatories, that's, yeah, moving on. It's rare as hen's teeth. It's one of those things that when you're a medical student you find really fascinating, but when you're actually qualified you never want to have to deal with. So non-steroidals are your aspirins, Nurofen, all of that sort of group, I'm sure you all know. They don't really have a central action. They have to be taken before the prostaglandin is released, and that's why for this group it's really important to take it really early. I use a lot of Anaprox. It's naproxenic with a sodium on it, so it lasts for 12 hours, and I tell my ladies to take 2 as soon as they think they might be getting pain or getting their period or whatever, and that cuts it off at the knees, and then they just need 1 every 12 hours for the next couple of days around period time. It works really well. I use that a lot, not for endometriosis ladies, but for my teenagers who are having trouble at school with periods and things. It works really well. The side effects, because they're prostaglandins, they work on lots of different things. Platelets, stomach, increases your acid in your stomach. So for non-steroidals work really well with arthritic type pain and joint pain. So if you use it every day long term, you get stomach ulcers and all of those sort of things. And for those of us who are old enough to remember Bex, Bex was a combination and it had high dose caffeine. Caffeine made you feel really good. But when you stopped having your caffeine, you got a blinding headache. So you took another one. And there used to be, you know, take a Bex and a good lie down was sort of the phrase, and it knocks off your kidneys. So it came off the market after a whole lot of women in Australia ended up on renal dialysis. Short term, it's fine. There's the Marinas, the IUDs. We first started putting in IUDs really to manage the menstrual issues with endometriosis, and we found, by accident really, that the smatterings of endometriosis within the pelvic region would often respond well to a Marina. And so it's not a bad form of treatment for your pain. The biggest problem, it's a very good contraception as well, the biggest problem is it's a foreign body in your uterus. And the more partners you have, and the more partners your partners have, the more likely you are to get an infection around the Marina. If you get an infection, it's really easy. We take it out and we give you antibiotics. The infection can block your tube, you need IVF to get pregnant. So it's a pretty high price to pay in younger women if they get an infection. It's great for the ladies who have finished their family. The other problem with the Marina is getting it in. It's a little bit thicker than a normal IUD, so putting it in is uncomfortable, which is doctor speak for hurt like hell. So a lot of women require a general anaesthetic to have it in, so that's a problem with it as well. Opioids, I'm a real, not quite anti-opioid, but I have grave concerns because I see the women who it really stuffs up their lives. And you can see that it's been fairly freely over the counter in the last few years, and the government's taken it off. And they've taken it off over the counter because it's killing people. And people are becoming addicted, depending on how you define addiction, I suppose. But our opioid deaths are really climbing in Australia, and they've climbed overseas. In the right place, it's great. In an acute pain management, it's fantastic. You know, post-op, it's terrific. But there's a dependency to it. It doesn't work so well, and it clouds your brain, so you don't think so clearly. And that can be problematic because if you're managing a lot of your pain by mentally coping and dealing with it and putting it there and not here and using all these other mechanisms that we have for surviving pain, if we cloud your brain, you can't do that as clearly, and you can't do all those other things that are really helpful when it comes to pain management and surviving and living with pain. So although it might have a short-term effect, long-term it's not that useful. So we all get to a stage where we kind of have this heart-sinking feeling where, you know, the patients come back and think, oh, what are they going to do with me now? And we sit there and think, oh my God, it's her, what are we going to do with them now? And nobody's, you know, really sure where the next step is and what we should do. The part of the problem is that we're not like, well, we probably were like that in those days, but we're not sort of the Doris Days where we're all the same fit now and we've all got the same look and we all do the same thing and we're all the same housewives, and we're all individual. And our endometriosis is very individual and it affects people differently. And it's a very complex, it has complex tentacles in the way it affects your life. So what works for one doesn't work for the other. It might help, but it's not necessarily going to do the right thing. So we have to really individualise what we do. The other problem with pain with endometriosis is we need to be very clear about what we're dealing with, and this is where I go back to harping on the diagnosis. It's estimated that 25% of women who have endometriosis also have irritable bowel. Now, it's probably a lot higher than that. So a lot of women will get pain from their irritable bowel and think it's their endometriosis. A lot of women will self-diagnose irritable bowel because it's easy on Dr. Google, and they do the gluten-free thing and they do the everything else thing, but they probably have endometriosis. And it's so common and it's so frequent that you wonder whether some of the beginnings of how you get this illness and how it occurs and the really basic scientific what happens with endometriosis and what happens with irritable bowel isn't a crossover. And does that make endometriosis perhaps more a immunology issue rather than a gynecological, there's a blob, let's take it out issue? One of the studies I was looking at, because I also do complex pelvic floor surgery and prolapses, incontinence, fecal incontinence, women who've had babies and all of that kind of stuff. And again, that's really good fun. But a lot of ladies with endometriosis get bladder issues. And for a long time we've thought, oh, well, you'll go in and you'll find a little bit of endometriosis on the bladder and, you know, take care of it and it'll be the same and it'll be fine. But a lot of them actually have no endometriosis on their bladder, but they develop interstitial cystitis and other issues with their bladder. Is it the same thing? Is it a consequence of their endometriosis? Does it happen together or is it separate? But when women talk about their pain, because they're so used to having endometriosis, they'll often come in and go, you know, I've got my pelvic pain from my endometriosis. They won't necessarily put it on the bladder. And so you really need to, every now and again, stop and think, what are we really talking about? Is it really endometriosis? Is there something else going on? What's really happening in the whole sort of process? And just because you've got endometriosis doesn't mean you can't have a stuffed back or a sore hip or a, you know, whatever else that might give you pain. I'm sure if you've come to these sort of talks before, seen this sort of cycle and this new well, it's not so new so much anymore, sort of this concept of everything that goes into chronic pain as opposed to just an episode of pain. I was recently at the English College conference, and there was a fabulous talk on how to get the NHS to set up a pain management clinic, because everything has to be cost benefit and whatever there. And pain management is really the way it all should work and happen. So in Edinburgh in 2010, they looked at their statistics and they did a deep dive into their data. And they found the 20 women who had used or the most or cost the most for their hospital in that 12 months. And they found there were 20 women, oh, surprise, surprise, they all had endometriosis. They had 56 clinic appointments, 102 emergency presentations. They had 40 admissions to the gynae ward, totalling 196 bed days. They had 50 ultrasounds and 12 laparoscopies in the 12 months. And they were women who had already been diagnosed, et cetera, et cetera. And so they used that and the costings for that to show that they really needed a pain management team who helped care for these women. And they got it. and they had really good statistics on how beneficial it was for the women who were part of all of that. So one of the things that we have been using for pain management over the last few years, for a while now, are things like antidepressants and anticonvulsants. And as soon as you bring it up, women think, you just think I'm crazy, you don't think I've got pain, and you're just fobbing me off. And the reality is a little bit different than that. Often in medicine, drugs are developed, and we find that they work pretty well for whatever it is that they're developed for. But we then realise they have side effects, and those side effects can be more useful in other places than the original reason we started the drug. So clonidine is a really old-fashioned antihypertensive. It works fantastically well on blood pressure. It's got a few little problems. And since then, there's been a lot more antihypertensives on the market. But clonidine works fantastically well on hot flushes. So when you can't use estrogen and you can't use hormone replacement therapy, i.e. all those women with breast cancer, clonidine is really good for your hot flushes. So clonidine is still on the market. Nobody uses it as an antihypertensive anymore, but we use it for hot flushes in those women. So a lot of drugs that started at something, we found another cause for, and that's really what the antidepressants, we wish they'd been named a different thing, such as amitriptyline, is really good for chronic pain. And it's the side effect of the drug that makes it good for chronic pain. It's not that you have to be depressed and it treats your depression and therefore your chronic pain. And so a lot of women are resistant to using these sort of drugs because of the labels that go with them, but they can be very useful in the right group. They need to be monitored. You need to pick them carefully, but they work really well. So the new concept of chronic pain, not just with endometriosis, or newish concept, with all sorts of chronic pain, is this sort of concept. I don't know whether you've had it before, but if you look at the top is normal and the bottom is abnormal and chronic pain. So the top, if you hit the very top one with something that's painful, like a fire or whatever, you have one set of nerves that tells your brain that that's pain. You have another set of nerves that picks up fine things like being tickled with a feather or light touch or those sort of things. And that doesn't set off your pain. But there is a little bit of a cross interaction, so the nerves know which receptor it's coming from. With people with chronic pain, the fine touch and the light touch also sets off the pain recognition centres. And that's why often with endometriosis or scarring or ladies with that sort of problem, there's this extra central layer of what's going on, which is why the antidepressants and the anticonvulsants and the Panadol with its central working has an effect in improving the situation. Does that kind of make sense? You're all looking a bit vague at this point in time, so I'll move on. So you need a team of people looking after you. They don't all have to be doctors, but you need sometimes a group of doctors. So if you do have irritable bowel, you probably need a gastroenterologist who is into functional care. A lot of gastroenterologists just want to do the endoscopy, colonoscopy to see if you've got polyps, and I'll see you again in 2 years. But there are a group who are interested in caring for people who have other issues. You know, the physios, the psychologists, the pain management doctors. And again, with the pain management doctors, again, sounding bitchy, they need a bit of experience with endometriosis because it's a sort of a separate part of the pie and that kind of thing. But you need a collection of people looking after you so that you get the maximum benefit. And so that women feel as though they really are being looked after and not being fobbed off and just passed over because you're a bit too difficult or a bit too tricky. So the last thing I was going to talk about is sacral neuromodulation. But with the last talk, one of the things that, again, maybe nobody's thought of and maybe I'm just jumping the gun, but with dyspareunia and dry vaginas, one of the trendy thing at the moment is vaginal lasers. Yes, you're all looking with a frown on your face, that's good. There's a company called Mona Lisa Touch, and they have sold a gazillion million lasers to everybody in Australia. And it's for those women who can't use estrogen, who have a dry, thin vagina, the laser treatment works well. The trouble is that there are no long-term studies. And the group who it works quite well with are, of course, the breast cancer women who can't use estrogen. So if they have long-term complications, at least they've had 5 or maybe 10 years of good sex before their vaginas start packing up again. But the studies are only 6 or 12 months out. And the laser treatments are being promoted as fabulous for everybody. And a lot of younger women are going to have their laser treatments just to, you know, shush up their vaginas for their new boyfriends. I don't get it. You know, so if anybody's tried to talk you into a laser for your dry vagina, be very wary at this stage. But moving on to more exciting things, Sacral Neuromodulation is pacemaker technology. So it's the exact same as a cardiac pacemaker. We just put it into the sacral nerves. We don't put it into the heart. So there's a battery. It's down on S3, so it's well away from the spinal cord. We use it for a number of reasons. It works fantastically well for chronic pelvic pain. It's just wonderful. We have trial leads, so we can put in trial leads where you just have the lead and it you know, it's a bit like having a drip in your arm. It just comes out. Put it on a battery on your waistband. You go home for a couple of days to see if it works. Ladies are ringing me on the phone within 24 hours. When can I get the permanent? You know, well, let's just give it a little bit longer. That sort of thing. It has been really interesting since we've been using this. Some women come in, they listen to me, they're on a gazillion million drugs, and they go away and they ring back and they say, thanks, but I don't think I want it. And that's absolutely fine. But all the ladies who've had the trial have come back for permanent. Now, we use it for other things, as I say, but with pain, we'll usually put in 2 leads if we're going to put them in permanently, 1 on either side. The battery is rechargeable. It usually lasts about 5 years. But with the other things, we put in a permanent battery and then we just change the battery after 5 years. But we find for the pain people, they need to recharge it every now and again. So it's a slightly different battery than the one in the picture, but it works fantastic. We put it in as a day case. For my old ladies, I keep them overnight just because I'm a very conservative surgeon and I don't want them to have a heart attack at home. I want them to have it in my hospital, post-op anaesthetic stuff, you know, type thing. But for everybody under the age of about 70, it's just simply day surgery and it works really well. So it's a day case, it's a general anaesthetic, it's very limited in public hospitals. You need private insurance because the technology is about $50,000, or unless you win lotto this weekend. As I say, the battery's about 5 years or rechargeable. It comes with remote control. There's lots of different programs. It's and you just Wi-Fi it or Bluetoothy to your thing, and you can change the programs and do all that sort of. But it works fantastic, and that's the trial is terrific because you can have a trial. It either works or it doesn't. And then last but not least, as well as being happy feet, this is what we really want to be. This is my grandmother. She died last year at 104.5. This is her at 104 before she got sick. She was absolutely fit and well and healthy and making my favourite apple pie. And that's what we want to be. We want to be fit, healthy women who enjoy all aspects of life forever and have a good time. So thank you very much.